Thank you for joining us. My name is Ann Grant, and I will be interviewing Dr. Douglas Yee today on topics presented at the San Antonio Breast Cancer Symposium. Thank you for taking the time to listen to us. Dr. Yee, we're so happy you could join us. I have a couple of questions for you, so let's get started.
Sure, thanks, Ann.
What stood out for you at yesterday's sessions? Is there anything that you'll take back to your practice?
Well, I think to put this in context, the morning session started out with a tribute from Drs. Larry Norton and Kent Osborne to Ms. Evelyn Lauder, the founder of the Breast Cancer Research Foundation. And one of the things Dr. Norton emphasized that Ms. Lauder's interest was in really pursuing research as a way to improve clinical outcomes. And for me, I think that's what this meeting is all about. So one of the very big topics in the morning that was interesting and important was to understand, are the ways to treat breast cancer that don't just treat the tumor. And that really goes around to the class of drugs called the bisphosphonates. So the bisphosphonates are commonly used for treatment of osteoporosis. They're used for treatment of women with advanced breast cancer with disease in their bones. And the several discussions yesterday revolved around whether the bisphosphonates were useful in treatment of women with early stage breast cancer. So we heard two updates. One of the updates was from the Austrian group, which confirmed their results that in premenopausal women who are made postmenopausal by an injection, bisphosphonates improve the outcomes for breast cancer, not just for the skeletal events, but for the outcome for the disease itself. The other thing we heard was another trial called ZOFAST. That was a little bit of a broader inclusion criteria, but they came to a very similar conclusion that the class of drugs, bisphosphonates, worked fairly well in women who were most estrogen deprived. And what I mean by that is that in the subset of women who had most clearly menopausal is where the drugs worked. Dr. Engel, who's been interested in this field for a long time, did a very nice review of the way bisphosphonates could work and the way the clinical trials were all in agreement, suggesting that the use of that class of drugs could be very useful in women who are postmenopausal or who are newly postmenopausal because of medical therapy. In other words, women with osteoporosis or ongoing bone turnover, you can improve their breast cancer outcomes if you inhibit that pathway. I think that's an important advance. The class of drugs is fairly well tolerated. There are complications and side effects, but certainly is by no means chemotherapy. But as the Austrian group showed, had the capacity to reduce metastasis, had the capacity to reduce new breast cancers, has the capacity to reduce breast cancer recurrences in the breast if there was a lumpectomy. And those are all important goals we have for cancer treatment. And again, to link that back to the research aspects of how we're all interested in this class of drugs really came from the understanding of bone biology and how bone biology interacts with breast cancer cells. And it's really great to see that we're starting to translate those findings out of people's laboratories into large clinical trials to improve breast cancer outcomes. I think the other thing that I was most impressed with was the ongoing discussion of how we should reorganize or rethink about how we do clinical trials. I think yesterday, throughout all the presentations, and not even counting the posters, there were probably 10, 15, 20, 25 drugs that looked very promising in breast cancer. It is complicated and difficult to do those trials where we do one at a time, where we really don't have a tumor to look at to watch it shrink. I think when we do clinical trials for new drugs, we need to understand what subset of women need them, how we best use them. So several trials demonstrated the ability to learn something by asking women to participate in clinical studies before they have their surgery. And that can go one of two ways. One was just donating a tumor and enrolling in a registry study so we can understand the molecular makeup of that tumor and see how the woman does with any therapy. The second trial design we've heard about with several presentations was what we call pre-surgical chemotherapy or neoadjuvant therapy, where women are given a drug treatment for either therapeutic intent for a long period of time or for what we call a window trial. Dr. Albain presented a very interesting trial where women were asked to take a new drug for roughly a week before their surgery. This particular drug is very interesting because it's called a Notch inhibitor. It has the capacity to knock out breast cancer stem cells or breast cancer tumor initiating cells. And Dr. Albane's trial is really directed to see whether or not that could happen. So she demonstrated that women prior to their surgery took a week of standard hormone therapy, and then they took another week of the new drug. And once that trial was done and they went to their surgery, she could test certain biomarkers that predicted potential benefit from this class of drugs. We also heard Dr. Artiaga, who received an award yesterday, the Brinker Award for Basic and Translational Science, showing the same thing, how we really need to understand in patients who have not been previously treated for breast cancer that combining drugs in the period of time before they go to surgery really does push and validate the research everybody's done in their laboratories. So to me, that's encouraging. It's encouraging that we're thinking that way. One of the things that I think is extraordinarily important is to have women understand that participation in these trials really moves the science forward that much faster.
It was a very interesting day yesterday, that's for sure. I do have one small question, and that is did I understand you correctly that by taking bisphosphonates, it could possibly allow a woman not to do chemotherapy? There are certain instances of that as well?
Yeah, I'd be reluctant to say that at the moment. So most of the trials have shown that bisphosphonates are used in addition to either standard conventional chemotherapy or hormonal therapy. The Austrian group was a trial where only premenopausal women were enrolled. They had their ovaries suppressed by a drug called goserelin, and then they were assigned to either tamoxifen or an aromatase inhibitor. And then they were assigned to either zoledronate or not. And as it turns out, so that trial had no chemotherapy. As it turns out, zoledronate substantially reduced the risk of recurrences in the absence of any chemotherapy. But certainly that question about could you think about other therapies to avoid standard cytotoxic chemotherapy is a hot topic. The other aspect is how do we make chemotherapy more effective and potentially even at lower doses so we don't run into the body side effects. As a medical oncologist, and I've been treating breast cancer patients, I want to make sure we understand that chemotherapy has really distinct benefits. And some women benefit tremendously from having had chemotherapy. A lot of what our improvements in breast cancer outcome are attributed to is a wider use of chemotherapy. But at the same time, we also understand that there are costs to be paid for chemotherapy. There are side effects and toxicities we'd like to avoid. And we also understand there are other buttons in the cell, so to speak, that you could push. Most of our chemotherapy is directed against cells that are actively dividing. There may be other ways to inhibit or kill cells besides just targeting DNA synthesis or DNA replication. And that's where the exciting part of this meeting is about, is that a lot of people have been thinking about this for a long time, and finally we had the drugs to be able to push the buttons we need to push. One of the other important, I think, presentations was Dr. Brugge's presentation on what she calls adaptive pathways. So if we think there's a button to push within a cell and we have a drug for that, other things pop up. And she showed very nicely in her model system when she gave a drug called BEZ225, which inhibits AKT or PI3 kinase and mTOR, that drug was effective, but the cell wants to avoid that. So it begins to activate other pathways. So it suggests that, well, maybe this is a good drug, but we need to have this in combination. I think the same thing goes with chemotherapy. Chemotherapy the class of drugs are good, but there probably could be better if we use them in combination and appropriately targeted other buttons, so to speak, while we gave chemotherapy.
It's not getting any less complicated, that's for sure.
Yeah, and I think that that's one of the most important messages. If anything, breast cancer is becoming an orphan disease. And what I mean by that, obviously it's a very common disease, but if we march down the various subsets of types of breast cancer, there's a very small set of women who are, for example, estrogen receptor positive, maybe HER2 negative, and have basal-like features. And that subset of women may need a very different therapy than the other types of estrogen receptor positive tumors. So the most important aspect for any kind of rare disease is having women help us participate in the studies. And I think that's the way we're going to go with a lot of studies now, is they'll be targeted to a very specific population of women. and that will have to enroll women to try to understand how best to use the drugs.
We certainly need a mechanism to get women to be able to participate in clinical trials.
Yeah.
Well, I'll go on to our next question.
Okay.
Do you agree or disagree with the IOM report that was presented yesterday on breast cancer and the environment?
Yeah, so the Institute of Medicine report, the very simple answer to that question, there's hardly much to disagree with because it was a fairly non-controversial or confrontational statement. And what I mean by that is I've heard the presentation. I haven't had the time to read the entire document yet, but it was very clear that there are some factors associated with cancer risk, and that this was a restatement of the factors that are known. So much of it was focused on lifestyle, in particular the idea that certain things that are associated with other diseases, physical activity, diet, might affect cancer outcomes. Those are all true. And I think it's true that that potentially could be a modifiable risk factor. And that statement, it's hard to disagree with the idea that we should have more physical activity. On the other hand, I think people were disappointed without a clear statement of having said that this is an area that needs to be addressed by policy change. I think what the Institute of Medicine report did was outline where we need to have additional knowledge. And I couldn't agree with that more. One of the very important things they highlighted was the idea that we don't have a very good understanding of early life events that are associated with breast cancer. So things that happen even in utero or during childhood, we have very poor understanding of how that could affect breast cancer risk, and that could be very important. But I do think people were disappointed in the fact that it didn't say, well, we need to ban, I'm going to use a substance, next substance could be different next week, bisphenol A, because it's associated with a clear link to breast cancer. We don't quite have that level of data yet, so the Institute of Medicine was being very cautious about saying that. And as disappointing as it was not to have a direct recommendation of we should do these things, the reason for caution, I think, is because we don't want to make policy changes that ultimately result in the wrong outcome. We don't want to say things that are associated with what seems like a good idea, but we're absolutely upside down. And in cancer prevention, we've done that. Not so much in breast cancer, but in lung cancer, we did clinical trials of vitamin A because there were population-based data suggesting vitamin A was a good thing. As it turns out, we learned that by doing the carefully controlled trial, that vitamin A was in fact harmful and increased the risk of developing lung cancer. So I think the Institute of Medicine is in a position to say, well, we can't have firm recommendations on what women should do because the scientific studies are not strong enough to make those recommendations. So as disappointing as it was, and not saying that, well, this is definitely what women should or shouldn't do, I think they were on target by saying this needs additional study. In the meantime, the things that women could do relate to diet, physical activity, and those things are probably true. At least for cardiovascular risk, those things are definitely true. But I, like a lot of other people in the audience, wanted to hear a little bit more beyond that. As I reflected on it a little bit more after the session, I think that as a sort of a official policy statement, they were being particularly cautious about what recommendations to make.
So in summary, I would say, do what your mother always told you should be doing, and it was a good first start.
I think so.
Would you say that?
I think it was very clear. One of the things about the Institute of Medicine report is that they can make recommendations that will change research policy, and that's important. I think if one of the outcomes of this was the highlight of we don't have enough information about early childhood or in utero exposures and breast cancer risk, and we need to actually understand that, it's possible that the various funding agencies, NIH or the National Cancer Institute or ACS or ACR or anybody could say, yeah, that's right, we need to actually study that, and we'll put out a specific request for applications or request for proposals to begin to try to understand that. So that's a positive step that could come out of this. Since it just was released yesterday, we'll have to wait a little bit more time to see how the recommendations are implemented. But that would be my most positive spin on this, is they really did highlight the areas that were of uncertainty and where more research is needed.
Great. Thank you very much.
Well, happy to be here. Thanks for the great questions.